in dispute with government, who have asked government to implement this National Health Act. There are two components of that National Health Act that should be very striking and interesting to Nigerians. One is the Basic Healthcare Fund, which is supposed to enable these primary healthcare institutions function very well, which is supposed to enable provision of basic healthcare services. Every Nigerian is entitled to a minimum basic healthcare services, and these basic healthcare services would include, at times of emergencies, accidents, emergencies, it is from these basic healthcare services that person is taken care of. And this is part of the reason why we are saying, let government implement this National Health Act. The Basic Healthcare Provision Fund is a pool of funds, part of it from at least a minimum of 1% from the consolidated revenue, and then from other sources, of which 50% is supposed to go for provision of these basic healthcare services.
Hold on with your thoughts. We're still with the national president of the National Association of Resident Doctors. Please join us after the break for more on the health sector. Welcome back. We're still with the national president of the National Association for Resident Doctors. Thank you for joining us once again.
Thank you so much.
Now, in all of your talk before we went on break, you mentioned medical tourism. What exactly is your grievance with that?
Grievances with that is that we have two components of medical tourism. The doctors that are supposed to be in Nigeria, trained in Nigeria, are supposed to be working to provide medical services to our Nigerians, are traveling out of the country. That's the brain drain. It's also part of the medical tourism. Now, we also have patients who could have stayed back in this country, had medical services offered to them, but because of their lack of faith in the infrastructure, equipment, and services we have in this country, they're traveling outside the shores of this country to get the same services that we could have given to them in this country at higher cost. So our people, our countrymen, are spending huge amount of money to go for medical services out of this country. Meanwhile, those services could have been available in this country. I give you a typical case, example. UNTH, University of Nigeria Teaching Hospital, is a cardiothoracic center of excellence. Practically, UNTH is supposed to offer open heart surgery. It's supposed to take care of any heart diseases, any heart problem, either by the cardiologist or by the cardiothoracic surgeons. Incidentally, at the same UNTH, we find out that we don't have optimal equipments and machines that we could use to take care of all those. But the personnel and manpower, they are there, but those equipments are not available. Now, you take another closer look. Recently, we have Kanu. Kanu has the capacity and ability to even do renal transplant in this country. The informations are not available, and some of the equipments they may also require to do some sophisticated surgeries are not also available. Yet, the capacity and manpower, they're all there. So these are part of our problem with medical tourism, because now take a look that some can afford it, the rich can afford it. Assuming you have somebody in Nigeria from that remote village that we are talking of, who incidentally may not have up to 3 million naira to travel to India, or to 6 million naira to travel to Germany, and then we are talking of in a country where dollar has also risen to almost 400 naira per dollar, and that person doesn't have that money. That means majority of our Nigerians are dying because of fund, because of money, because of accessibility of health services.
But then the Minister of Health really, because I get the impression that you think he's not cooperating with your needs. So just to remind you that he said that there are funds coming in from the World Bank and global funds, and these are fundings, I mean, that we hope to see significant improvement in the sector. Does this not add anything, you know, to whatever dearth there might be at present?
We also hope to see significant improvement. We have been hoping to see that significant improvement since 2013, 2014, 2015, 2016. This is 2017. Let us also keep hoping to see that significant improvement.
So why are you on strike?
Because that hope has not translated into action, into visible evidence. And that is what we are asking for. It is no more time for talk and talk and talk and talk. It is time to practicalize the talk. It is time to put those talk into action.
We are trying to look at this whole, issue, the issues rather, more objectively, because again, I would like to say here that the government says that it will implement the universal health coverage. in 2017, and it targets to provide accessible and quality health care and all of that. So when we look at these things in the pipeline, it's either one of the two. You're not confident that the government will do what it has said, or or there are a lot more issues than we're seeing, because a lot of people say it might be welfare or infrastructure.
Definitely. If you remember again in 2013, such statements was also issued by the government.
So you don't have confidence in the government?
2014, the same thing. 2015, the same thing. We want to see the commitment of government in what they have said. It's not just enough to say we'll do that. It's not just enough to say we've consulted the committees in the National Health Act, but want visible evidence that their effort is being made at constituting those committees. Now, that has been the lingering, why we have had all these problems lingering. Now, coming to our welfare issues, it has always also been there. Oh, we are committed, we are going to solve those problems, we've started solving them. At the end of the day, we'll still come back to the same issue in the next year, because they were all talked about and they were not implemented.
Are you aware of the policy of no work, no pay?
That is another interesting area. We are aware of that policy of no work, no pay. But our issue with the policy of no work, no pay is that it's selectively applied to our members.
How do you know?
You're also aware that ASU was on strike for about 10 days and they were paid. You're also aware that in Federal University of Technology, Akure, they've been on strike for 7 months, they were also paid. In the same health sector, the other health workers have, at different institutions, different places, been on strike. Take, for instance, Owerri, they've been on strike since October, and they'll be receiving their salaries. Take, for instance, National Orthopedic Hospital.
So you hope to go on strike and still be paid?
No, that is not what we are saying. Our members had legitimately demanded for their rights in the past. And at the same time, why Ministry of Health applied no work, no pay to them, which we see as selective application, victimization, they did not at the same time apply the same no work, no pay. That is double justice, double jeopardy. And we think that in as much as we are not saying go and deduct them, because even the policy of no work, no pay is discretion.
Thank you very much for coming on Dateline Abuja.
Thank you so much.